Hi guys, welcome to this neuropath session on CNS tumors. So let's get started. So firstly, CNS tumors may either be primary or secondary. So primary CNS tumors are those tumors that arise from the cells of the CNS, which are either the neurons or the neuroglia, sometimes even the meninges. And secondary CNS tumors are those tumors in the CNS that metastasize from another site. So another malignancy metastasizes and spreads to the CNS. It's important to remember that these secondary tumors are more common in the CNS than the primary tumors of the CNS. So before we discuss in detail about the primary and the secondary tumors, let's talk about the common clinical features that are found in all CNS tumors. So irrespective of the tumor, these clinical features are similar. So first and most important clinical feature we'll talk about is headache. So they usually have a persistent headache lasting for a few months and not relieved on the normal analgesic medication. It sometimes is worse at night or early in the morning. The second important clinical feature that you should know is seizures, and this is particularly common in the tumors that involve the cerebral cortex. The third thing which could be there are some mental changes, some behavioral changes. It's not too common, but it could be there depending on the site of the tumor. And the last thing is the focal neurological deficits. So depending on the site of the tumor, they may have weakness or inability to speak, inability to comprehend, deafness. So all of these could be present depending on the site of the tumors. So 4 things you remember: headache, seizures, some mental changes or disturbances, and lastly focal neurological deficits can be there. If the CNS tumors obstruct the CSF flow, you could also have features of obstructive hydrocephalus. Next thing we want to talk about is, although secondary tumors are more common in the CNS, or metastatic tumors are more common in the CNS than the primaries, it's important to note that primaries rarely metastasize. So a CNS tumor rarely spreads to the breast or lungs, or it doesn't go vice versa. So secondaries are more common in the CNS, but CNS tumors rarely metastasize. So now we'll talk about the differences between the primary tumors and the metastatic or secondary tumors. Okay. So first we'll talk about the primary tumors. So these are the tumors that arise from the cells of the CNS. They are usually poorly circumscribed tumors, usually single, and the location can vary depending on which tumor it is and from which cell it's arising. Whereas the metastatic tumors are usually multiple in number and they are well circumscribed lesions. They are commonly located at the junction of the grey and white matter. So where are the common sites that the metastatic tumors come from? So firstly, CA lung. So the most common site where brain tumors metastasize from are CA lung. So carcinoma lung is the first thing you have to remember. The second most common site is CA breast. So both lung and breast carcinoma frequently metastasize to the brain. Other than this, it's also important to note a few other malignancies which include thyroid, melanoma of the skin, lymphoma of the blood, and choriocarcinoma, which is a gynecological malignancy. So these are the common malignancies that metastasize to the brain. And let's review once more. Primary CNS tumors are usually single and poorly circumscribed, whereas secondary or metastatic CNS tumors are well circumscribed and multiple in number, usually located at the junction of the grey and white matter. One more point that I'd like to put forward is that another pathology found at the junction of the grey and white matter, which acts as a differential for the metastatic tumor, is your brain abscess. Okay, so this is a point you can note. So how do you differentiate a metastatic tumor and a brain abscess? Usually brain abscesses are solitary, whereas metastatic tumors are multiple. Both are well circumscribed. So that was the difference between the primary CNS tumors and the secondary CNS tumors. So now this discussion will be mainly limited to the primary CNS tumors. So to understand the primary CNS tumors, we must first know what are the normal cells found in the brain. And only if we know what the normal cells are, can we understand the malignancies that arise from each of these cells. So all of these cells can give rise to different kind of malignancies with different features. So first, let's talk about the cells of the brain. So the CNS consists of two kinds of cells broadly. The first kind are your neurons, which are the principal cells of the CNS, and the second are your neuroglia, which are the supporting cells of the CNS. So let's talk about the neuroglia. So neuroglia, there are three important neuroglia or three important supporting cells that we should know about. The first one is the astrocytes. These are star-shaped cells that help form the blood-brain barrier. The second neuroglia we'll talk about are the oligodendrocytes. So oligodendrocytes are those neuroglia or supporting cells that help in the myelination of the neurons of the central nervous system. And the third important type of neuroglia we'll talk about are the ependymal cells. So what are the ependymal cells? The ependymal cells are a neuroglia or a supporting cell that forms the lining of the ventricles. Ventricles are CSF filled spaces in the brain, and the lining of these ventricles are formed by ependymal cells. Okay. Now, other than these, you should also know there are some meningothelial cells. You know the brain is covered or surrounded by a meninges, and the cells that are present in this meninges are called meningothelial cells. So these are four important cells you should know about in the nervous system other than the neuron. The fifth type cell is the principal cell, which is the neuron. We will talk about that in further detail little later. Also, I want to add one more cell to the mix, and that is the Schwann cell. And these Schwann cells are again supporting cells that are found in the for the cranial nerves and the peripheral nervous system, and they have the same function as the oligodendrocytes, which is myelination, but again of the peripheral nerves and the cranial nerves. Okay, so coming to the malignancies that arise from each of these cells, the common ones which are seen in children and in adults. So from the astrocytes, we have the juvenile pilocytic astrocytoma or just pilocytic astrocytoma in children, glioblastoma multiforme in adults. From the oligodendrocytes, we can have oligodendroglioma, which is seen in adults. The ependymal cells can give rise to ependymoma, which is seen in children. The neurons can give rise to medulloblastoma, which is seen in children, and the neurons do not give rise to any tumor in adults. So let's go back to some basic pathology. We know from physiology that neurons are cells that rarely divide, and especially the neurons of the central nervous system rarely divide and do not divide. So they have lost their capability of division with maturity. So as neurons mature, they lose their capability to divide, and therefore any cell that loses its capability to rampantly divide also loses its potential for malignancy, because malignancy is essentially uncontrolled division of cells. So this cell has no potential to divide, and therefore since neurons are not dividing, they do not cause any malignancy in the adults or any CNS malignancy in the adults. Lastly, the meningothelial cells can give rise to meningiomas, which are again common in the adult age group. Now we will talk about each of these tumors in significant detail. Okay, so before we move on to discussing each tumor in detail, I want to put forward a very important and very high yield concept. Okay, so this is a picture of a section of the brain, and I have drawn a plane here which is called the tentorial plane. Okay, so the tentorial plane is a plane that passes between the cerebrum and the cerebellum of the brain. In simple terms, that's what the tentorial plane is. Anything that lies above this plane is referred to as supratentorial, and anything that lies below this plane is referred to as infratentorial. Okay, so why is this important? Remember, all the tumors of children are found infratentorially, whereas tumors in adults are found supratentorially. That's all you need to know. So tumors in adults are usually found supratentorially, whereas tumors in children are usually found in the infratentorial space and the posterior fossa. So what all are there in the supratentorial space? You have your lateral ventricle, third ventricle, and cerebral convexities. Okay, so these are the common sites of tumors of the adults, which we discussed about earlier, and infratentorially you have the cerebellum and the fourth ventricle, which are the common sites of tumors of children, again which we discussed earlier. So remember, children are inferior or smaller rather, so infratentorial for children, adults are superior, so or above them, so supratentorial for adults. Okay, so that's how the tumors divide in an anatomical way in the CNS. So now let's talk about the first tumor, which is also the most important tumor in the discussion, the astrocytoma. So we already said astrocytes are cells that form the blood-brain barrier of the brain, and astrocytes are the tumors that arise from these cells. So one thing you have to remember is that this is the most common primary malignant tumor of the CNS, particularly GBM, okay, which I'll talk about in detail. But remember, astrocytoma, particularly glioblastoma multiforme, is the most common malignant tumor of the CNS in adults. Okay, so based on the cellular atypia or the dysplasia that the cells display, WHO has graded astrocytoma into 4 grades. Okay, so grade 1 is the juvenile pilocytic astrocytoma or just pilocytic astrocytoma. Grade 2 is the fibrillary astrocytoma. Grade 3 anaplastic astrocytoma, and grade 4 glioblastoma multiforme. It's important to note that as you go from grade 1 to grade 4, the atypia increases. So there's more atypia in grade 4 as compared to grade 1. Similarly, the aggressiveness and the malignant potential also increase. So juvenile pilocytic astrocytoma being the least malignant and least atypical, to glioblastoma multiforme being the most malignant, most aggressive and most atypical. So among these 4 grades, grade 1 and grade 2, grade 1 and grade 4 are the most questioned, most most commonly asked and most high yield grades of this tumor. So we'll talk about those in detail, and grade 2 and grade 3 very briefly. So firstly, the pilocytic astrocytoma. This is a low grade tumor with good prognosis. So I told you it's grade 1, so therefore it's a low grade tumor with a good prognosis, and it is more common in the children and young adults. Hence it's also called juvenile pilocytic astrocytoma. Juvenile meaning children or young. So since this is more common in children, it's also called juvenile pilocytic astrocytoma. And just like all tumors of children, it is an infratentorial tumor, which essentially means it usually affects the cerebellum. And since it's a low grade tumor, it's a well circumscribed tumor, and the cells show a good amount of differentiation. And this tumor is usually cystic in nature. So you can remember it as pilocystic astrocytoma. Although that's not factually correct, it's just an easy way to remember that this tumor is cystic in nature. Now, so that was the gross findings. Now the histopathology. So in the histopathology, you need to only remember 2 things. The first thing is that this tumor is composed of astrocytes which have long fibrillary processes and are hence called pilocytes. So pilocytic means hair-like cells. So these astrocytes, which are usually star-shaped cells, develop long fibrillary processes like this, which look like hair and are hence called pilocytes. Okay, so astrocytes having long wavy processes, and some of these processes get thickened to form thickened eosinophilic processes, and these are called Rosenthal fibers. So what are the 2 things you remember for HPE of pilocytic astrocytoma? The first thing is that the astrocytes develop long wavy processes and are hence called pilocytes. And the second thing is some of these pilocytes get thickened to form a thickened eosinophilic or pink process called the Rosenthal fiber. Now we'll look at the photos, so it's engraved in your mind for good. Pathology is all about photos, right? So here you see the astrocytes with long wavy processes. Beautiful. So long wavy processes. So therefore they are pilocytes, and you see some eosinophilic thickenings here and there, right? You can look at all these eosinophilic thickenings, which are nothing but the Rosenthal fibers. So only 2 things you have to remember, which are very important for this tumor. Other than that, you know that the cells are also well differentiated. You can make out that these are astrocytes. So the other point I told you was that this is a cystic tumor. So in imaging, this tumor has a cystic region with a small nodule on the wall of the cyst. So you saw this black area which is the cyst with a small nodule on the wall of the cyst. So this small nodule that you see on the wall of the cyst is called a mural nodule. Okay, so you know mural means something on the wall. So a nodule on the wall of the cyst is called a mural nodule, and this appearance of a mural nodule is a classical finding in the CT scan study of a pilocytic astrocytoma. So remember this picture very well. Okay, mural nodule. Okay, so that was about juvenile pilocytic astrocytoma. The next is the grade 2 tumor or the grade 2 astrocytoma, which is called the fibrillary astrocytoma. So remember, although this is worse than juvenile pilocytic astrocytoma, it still has a decent prognosis. So it is a well differentiated tumor, common in the 3rd and 4th decade of life. Grossly, it's a poorly defined tumor, not as well defined as your pilocytic astrocytoma, but microscopically the cells are still well differentiated, so it's not as dangerous. So all you have to remember about fibrillary is that it's found in the 3rd and 4th decade of life, and microscopically you can see astrocytes with a fibrillary background or astrocytes in a fibrillary background. Now grade 3 anaplastic astrocytoma. So this is a more malignant tumor, and it usually evolves from the lower grade astrocytomas. Okay, so all you have to remember about grade 3 astrocytoma is that now the tumor is completely anaplastic. So all your features of anaplasia, which include the hyperchromatic nucleus, decreased NC ratio, hypercellularity, loss of normal cellular architecture, so pleomorphism, all these things are seen in grade 3 anaplastic astrocytoma. Not too important from the exam point of view, it's just here for completion's sake. Now the most important tumor we'll discuss about in this segment is the glioblastoma multiforme or WHO grade 4 astrocytoma. Why is this tumor important? Because it is the most aggressive tumor. It's the most common primary CNS tumor and also the most aggressive tumor. So this is a high grade malignant tumor of the astrocytes, most common tumor in adults, and it predominantly is found in the cerebral hemispheres. So like we discussed earlier, tumors in adults are supratentorial, so it's predominantly found in the cerebral hemispheres. So how do these tumors look grossly? So if you look at the brain, what do you see? So you need to remember there are 4 things which are important grossly in your glioblastoma multiforme. The first one is that it has a classical variegated appearance. So it has some gray white areas and some yellow areas. So that is called a variegated appearance. It's a variance in the colors. So there will be some gray white areas and some yellow areas. The second point is there are lots of areas of hemorrhage and lots of necrosis. So this is one of the most necrotic tumors. So the second point is there are lots of areas of hemorrhage and lots of areas of necrosis. And the third point, which is specific to this tumor and the most important point, is that these tumors cross the midline. Okay, so very rarely do you see tumors crossing from the right hemisphere to the left hemisphere or the left hemisphere to the right hemisphere, but these tumors have the tendency to do that and therefore are sometimes called butterfly glioma. I'll show you a photo which will seal this fact. But yeah, remember, these tumors can invade the corpus callosum and even pass the midline. Those are 3 important gross features that you will see in glioblastoma multiforme. So now let's put these gross features or let's seal these facts in our mind. So look at the photo here. Firstly, you can see the variegated appearance. There are some yellow areas here and there are some whitish areas here. You can see these regions of necrosis and hemorrhage. So you get reddish regions of necrosis and hemorrhage. And lastly, you can see that it's crossing the midline and you can see a beautiful butterfly like shape. See, I can draw a butterfly here, right? So you can see a beautiful butterfly like shape when it comes to these tumors. So I'll just clear this up for you so you can see it again. This is a highly high yield image. So crossing the midline, sometimes pushing the midline, and lots of areas of hemorrhage and necrosis. So highly necrotic, dangerous tumor. Remember the term butterfly glioma for GBM. Okay, B for G butterfly and GBM butterfly glioma. So that is the gross appearance. Now in the imaging, how does it look? Again, at first glance, you can see that there is a butterfly-like shape in this image, right? You can see there's a butterfly-like image. Few things you have to focus on in this image. Firstly, there is these black areas are areas of necrosis. So there are many areas of necrosis. Second point, it crosses the midline. And third point is you can see an enhancement or a hyperdense area around this region of necrosis. So these are the three classical things you see in the imaging of a glioblastoma multiforme. And if you see a picture like this as a question, you know the answer is GBM. Very few tumors cross hemispheres, and this is a very typical picture. So remember, ring enhancing lesions is seen on imaging. Remember these two pictures very well. Now that we've talked about the gross and the imaging, we'll talk about the histopathological features of this tumor. So first thing you have to remember is, I told you this is a very aggressive tumor. So they are highly anaplastic. All your features of anaplasia are seen in these cells, and the cells are poorly differentiated and large in number. So there is hypercellularity, highly anaplastic cells with all those features. Hyperchromatic nucleus, decreased density ratio, cellular pleomorphism, loss of normal architecture, loss of basal polarity. So all those features are seen. So this is common to most tumors, so we won't delve into it. So the first point you'll write is highly anaplastic, all features of anaplasia seen. The next 2 points are the most important, and you should remember them. The first of them is the easy point. So there is lot of necrosis. So multiple areas of hemorrhage and necrosis. So you will see lots of areas of hemorrhage and necrosis in the tumor. It's highly necrotic tumor. The next thing you should know is about the pseudo palisading arrangement. So what is this pseudo palisading arrangement? Let's look at the picture. So here I'm outlining it. You see this pinkish area with lot of vacuolated region. That is the area of necrosis. And if you look around this area of necrosis, you will see a lot of these malignant cells around this area of necrosis. It looks like they are surrounding or around this or collecting around this area of necrosis. You know, all these malignant cells surrounding an area of necrosis or this pool of necrosis. So this arrangement is called a pseudo palisading arrangement. So remember, palisading means to stand in a row, and in this picture it looks like all these cells are standing around the region of necrosis. So the second important point you should remember is that there is a classical pseudo palisading arrangement seen. And what is pseudo palisading arrangement? I've showed you in the image also. It is a region of vital cells that surround the area of necrosis. So we've talked about the basics of CNS tumors, and we've talked about astrocytoma in this segment of this discussion. Remember the most important points: butterfly glioma, ring enhancing lesion, and lots of necrosis with a classical pseudo palisading arrangement. Now in the next segment of this discussion, that is CNS tumors part 2, we'll discuss about the pathology of all the other tumors. Okay, so thank you.